Good morning, everyone. Thank you, Manoj. And again, I'm grateful to Professor Sareen, Manoj, and everyone for inviting me out here. So, I'll be talking about inflammatory bowel disease. So, maybe in the sense that since it's an Institute of Liver and Biliary Sciences, so I thought that IBD may be a kind of slightly alien topic for you. But then at the same time, what is happening in India is that we are seeing so many cases of IBD, so many cases of ulcerative colitis and Crohn's disease, that every gastroenterologist or any hepatologist or a gastroenterologist, they're bound to see such cases. And not only mild cases, but very complex cases. So I thought it is a good opportunity to take you that how the kaleidoscope of IBD treatment is changing or has changed over the last 2 or 3 decades and continues to change. So I'll start with 2 or 3 some representative cases. Like a lady who came to us ulcerative colitis, steroid dependent, azathioprine refractory. So obviously she requires the next level line of treatment. She also has certain comorbidities in the form of transverse sinus thrombosis, has a history of subarachnoid hemorrhage. She has dilated cardiomyopathy with ejection fraction of 50%. So the question is, what advanced therapy will you give? Now you'll ask me, what do you mean by advanced therapy? In the sense that till now we have been talking about biologicals in IBD. In ulcerative colitis and Crohn's disease, we have been talking about monoclonal antibodies. So what is this new term? Well, it is a new term, advanced therapy. It is so because now not only we have the monoclonal antibodies, we also have the oral small molecules. So we had, let's say, only infliximab and adalimumab a few years back, but now we also have the JAK inhibitors, ozanimod is coming up. So clearly out here, the gamut has increased. So what would you do out here? Like any postgraduate student would like to take a guess, like you would like to give infliximab, she's not responding to steroids, she's not responding to azathioprine. So what would you do? Would you like to give infliximab, adalimumab, vedolizumab, ustekinumab, any guess like? Any guess is welcome, any answer. What would you like to give? So out here, the basic thing is that, any guess? Infliximab or vedolizumab or ustekinumab? Adalimumab is? So out here, the thing is that she has dilated cardiomyopathy. She has an ejection fraction of 50%. So once you have this kind of comorbid illness along with IBD, then you would not like to give TNF inhibitors. You would not like to give infliximab or adalimumab. These are 2 agents which you will not give. So this is just a kind of case scenario to tell you that how there are various nuances in treatment and how you have to navigate through them. Another case which came to us, 38-year-old male from Delhi, August 24, large bowel diarrhea, colonoscopy showed changes suggestive of ulcerative colitis. The case was straight away started outside on tofacitinib 10 milligram BD along with 5-ASA. Do you think this is the correct approach, or do you think possibly this approach may not be correct? What do you think? You think this is, how many of the postgraduates out here think this is the correct approach? Well, this is not the correct approach because tofacitinib is part of advanced therapy. Here a patient has come with one episode of large bowel diarrhea. You do not even know whether the patient has infective diarrhea or the patient has ulcerative colitis. And here the first line therapy would be 5-aminosalicylic acids, and straight away the patient has been started on advanced therapy. Another case, 30-year-old lady, known case of ulcerative colitis with disease extent limited to rectum, proctitis. Relapse while on 5-ASA. Has been given previously one course of steroids. Being followed up in California, and since her parents were here, so she came visiting Delhi, and she said that she came to AIMS for another opinion, that okay, I have been advised vedolizumab in California. Do you think that is the correct approach? No, that is again not the correct approach because he has very limited extent of disease. Doesn't seem like a very aggressive disease. Only one course of steroids given in the past. So obviously you would like to manage out here with maybe another course of steroids or topical therapy. Another case, 50-year-old small bowel strictures Crohn's disease. So these are the various kind of therapies which are available for this patient. It's a known case of, we know that he has Crohn's disease, he has small bowel structuring disease. Would you like to start this patient on steroids, or would you like to start this patient on infliximab, adalimumab, advanced therapy? Well, here since it's a case of Crohn's disease, it's small bowel stricturing Crohn's disease. That means it is an aggressive Crohn's disease. You would like to start the patient on advanced therapy, which may be in the form of maybe, let's say, anti-TNF inhibitors. So adalimumab was started. However, anemia persisted. The patient persisted to have a lot of anemia, not responding. So what will you do? You have to sequence your therapy. Sequence your therapy means go to another agent which has a different mechanism of action. So here ustekinumab was started, but anemia persisted. Now what do you do? So what you do out here is you combine two agents. So we combine two agents. Ustekinumab and vedolizumab were started. Anemia persisted. Still the patient is not responding at all. What do? You go to the surgeons then and see whether it is possible to take off a part of the small intestine, the part which has the disease. So surgery was done, surgical resection was done. Do you stop out here? No. This patient has an aggressive Crohn's disease, and you know that surgery is not curative for Crohn's disease. There's bound to be a recurrence out here. So the patient was started back on biologicals and then thereafter doing well. So these are 4 cases just to tell you where the field has gone to today. In the sense that it is a field where you have to have, there are certain nuances, has to be some in-depth understanding of the kind of agents which are available and when you're going to use it, and that is what I'm going to talk about today. Just 30 years back, Professor Saraya, previous head of the department, is here, a very dear teacher and a friend both, and he would say that 30 years back, like he would remember, like I was a gastroenterology resident and he was just joined as assistant professor. So that time, cyclosporin, azathioprine, methotrexate, these were the only lines of treatment available. And if you look on the right-hand side, the benefit is 70%, 80%, that's what people thought about. And this is in black and white and just 30 years back. In 30 years back, from this black and white scenario, the kaleidoscope has become definitely much more colorful. You have a huge number of agents which are available today, which have various mechanisms of action, and 80 to 90% of them are available in India. The problem is that still the cure is not there. Most of these agents, they are immune therapy agents which control the inflammation. So you may use them to control inflammation. They may lose their response after a period of time, but at the same time, they do not cure the disease. So that is the first message you should take when you're going to use advanced therapy in IBD, that advanced therapy in IBD, however sophisticated it may be, however expensive it may be, but it is not going to cure the patient of their disease. It is possibly only going to control the disease. But do all patients require advanced therapy? Is it going to be a knee-jerk response for you that any case of ulcerative colitis or Crohn's disease comes to you would like to start the patient on biological oral small molecule? No. If you look at 100 cases of ulcerative colitis, you would find that 80% of them require just mesalamine. They respond well to mesalamine in between a few courses, or in between 1 or 2 courses of steroids at best in their lifetime. Whereas 20% of them have an aggressive disease, 10% would require biologics, 10% would require surgery. Surgery is curative in ulcerative colitis, so that is why it is useful. The only thing is in ulcerative colitis, it's a 3-step surgery, ileal pouch, anal anastomosis. So it is a very tedious surgery. There's a 20% risk of pouchitis and other complications associated with the surgery. So that is why surgery does not consider a very attractive option. So 20% cases are aggressive in ulcerative colitis. In Crohn's disease, 40% cases are aggressive. 60% of them have a quiescent behavior. It's not that every case of Crohn's disease is progressive. So these 40% of the cases are one which have a stricturing disease, penetrating disease, perianal fistulizing disease, and these are the ones which will require advanced therapy. So the trick is in deciding which cases are going to have an unfavorable course and which cases are going to have a favorable course. Because if you pick up a case which is going to have a favorable course and you unnecessarily escalate the treatment, that is like leading to risk of over-treatment, risk of infections, obviously a huge economic burden on the patient. Whereas certain patients who are going to have a very progressive disease, if you do not pick them up, then obviously by the time you end up treating them with advanced therapy, they would have gone into intestinal failure. So the trick out here is first is when a patient walks in, you get a picture in your mind, this patient is going to have an aggressive disease or a non-aggressive disease. Aggressive disease means I put the patient on advanced therapy. Non-aggressive disease, I do not put the patient on advanced therapy. In Crohn's, how do you decide that? In Crohn's, you decide that, okay, young male smoker is fine, but essentially a stricturing disease, penetrating disease, perianal fistulizing disease, extensive small bowel disease, history of previous bowel resection, corticosteroid requirement which has been perpetual. If these are 4 or 5 general features which are present, then you know this patient should move on to advanced therapy. This patient has a progressive disease course. Similarly, in ulcerative colitis, if a patient has extensive colitis, pancolitis, previous 1 or 2 episodes of acute severe ulcerative colitis, corticosteroid requirement which has been again very, very chronic, and along with that severe endoscopic activity, you know this patient also is not doing well, and this patient may have to graduate beyond 5 ASA or azathiopine, etc. So the first thing is to pick up these scenarios out here, so that you can decrease the risk of under treatment and at the same time decrease the risk of over treatment, both because you have so many therapies available. Earlier there were only 2 therapies available, so this risk was not there. You didn't have too many avenues to treat, so obviously you would not fall into any of these traps. Now these traps are there. Still, the biggest trap I would say remains, particularly for Southeast Asia and India, is the thing whether you would like to, whether the diagnosis is correct or not, whether you are accurate about your diagnosis. Why? Because Crohn's disease does not have a single gold standard test to make a diagnosis. It's not that you can send a serological test, or you can send, like for typhoid, you can send a blood culture, or for tuberculosis, you may send a gene expert and be very sure about the diagnosis. You cannot be sure about the diagnosis out here because it's a diagnosis of exclusion. Ulcerative colitis, again, you do not have a single gold standard test to make a diagnosis, but ulcerative colitis, it's still easier to make a diagnosis because colon is very accessible to colonoscopy and biopsies, and you can keep on repeating the procedure. So even in the best of the centers, despite a lot of experience, people keep on burning their fingers when it comes to making a diagnosis. So be very sure about the diagnosis. I'll just illustrate 1 or 2 small cases to show that how these patients, they were started on advanced therapy or something, they were graduating to advanced therapy, but possibly whether the diagnosis was correct or not. 29-year-old man, somewhere in 2019, he had perianal pain, perianal discharge, thought to have perianal fistula, evaluated more, subsequently develops rectourethral fistula, thereafter undergoes CT as well as colonoscopy. Colonoscopy shows certain changes which are suggestive of Crohn's disease. So since he had anemia, he had a persistent perianal fistula, he had colonic involvement, so but natural that he was labeled as a case of Crohn's disease with a duration of 3 years, and it was decided that this is a patient who requires advanced therapies, started on infliximab, 4 doses given, but the patient did not improve. Instead, what he developed was a new finding, that is dysphagia, odynophagia, and vomiting. So the patient who started with colonic and perianal involvement also seemed to have esophageal involvement. Now the question was what not to do. So the patient, when he came, was re-evaluated, and it was found actually that he had a retroviral disease, and along with that, VDRL was positive. So possibly it was syphilis, which was involving the esophagus. It was causing perianal fistulae, which is rare, but then that is true in this case. The patient was given antiretroviral therapy, was given dose of benzathine penicillin, and he improved remarkably. He is a patient of infectious disease given biological therapy, obviously because the presentation was very, very similar to Crohn's disease, and anybody would make a diagnosis of Crohn's out here. Another young girl, 24-year-old lady who was symptomatic for 6 to 7 years, lot of diarrhea, pain abdomen, weight loss, typical presentation, you would say it is tuberculosis or it is Crohn's disease. She kept on getting evaluated at various centers, endoscopy, colonoscopy, MR angiography, initially normal. Then an enteroscopy was done, which showed that deep in the ileum there was friable, unhealthy mucosa. A capsule endoscopy was also done, which confirmed the presence of multiple clean-based ulcers in the ileum. She had anemia, she had hypoproteinemia, 1 or 2 courses of steroids were given, to which there was a partial response, not much response. She was kept on enteral nutrition, so the question was obviously this patient is a Crohn's disease, not responding to steroids. You have evaluated for TB, so should this patient be put on infliximab? So while talking to the family that whether we should start the patient on infliximab, still we thought, why not just go ahead and take another more chance. So did a retrograde spiral enteroscopy, which showed presence of deep ulcers and superficial and deep ulcers again in the ileum, but it gave the option of taking another set of biopsies. So another set of biopsies was taken, and when the biopsy report came, it showed a lot of strongylloidosis larva out there. So we thought that it is strongyloidosis, which is superimposed or a superimposed infection on a case of Crohn's disease. So let's think strongyloidosis. But is it possible that from 6 years she's having strongyloidosis? She has received 2 courses of steroids. You know that steroids can cause dissemination of strongyloidosis. It can be catastrophic. So she was given prolonged courses of ivermectin for strongyloidosis. Obviously, there is no entity called as chronic strongyloidosis, but here we were seeing a case over 6 years which had obviously been manifesting these kind of symptoms. So the proof lay in going back 6 years, 6 months back, and trying to find out if the patient still has ulcers or not. Patient had remarkably improved clinically, had improved biochemically, and when you did the enteroscopy, again it showed the mucosa was totally normal. And the lady is very fine till date. Again, here, if biological therapy had been started, it would have been disastrous for the lady, and everybody would have thought that it's a case of Crohn's disease which just went into intestinal failure or infection. So be very sure about the diagnosis. Do not overtreat, at the same time do not undertreat. These are the various agents which are available to you since the topic is newer drugs, so I'm going to talk about newer drugs only, or in the sense the advanced therapy. I'm not going to talk too much about basic drugs. TNF antagonists, anti-integrins, anti-interleukins, JAK inhibitors, sphingosine 1-phosphate receptor modulators. Briefly, what are the mechanisms of action? Infliximab, adalimumab, certolizumab, golimumab. They are all TNF inhibitors. Macrophage is the main source of TNF alpha. TNF alpha is secreted by the lymphoid cells also, the T lymphocytes, the B lymphocytes, but the innate cell, that is a macrophage, seems to be the main source of TNF alpha. And what infliximab and adalimumab do is they neutralize the membrane bound as the TNF alpha as well as the soluble TNF alpha, which leads to decrease in the inflammatory marker. Second is that you want, what is the site of battlefield? That is the lamina propria in the intestine. So how does a battle take place? The activated lymphocytes, they leave the lymph nodes, they go to the blood vessel. From the blood vessels, they migrate across the endothelial wall and go to the lamina propria, where they start fighting. If you can stop the lymphocytes from reaching the site of inflammation, obviously that would be wonderful. So there comes in lymphocyte trafficking inhibitor or vedolizumab. How does it act? That all the gut-homing lymphocytes, they have a receptor on it, which is alpha-4 beta-7. Alpha-4 beta-7 interacts with the MATCAM receptor on the endothelial cell wall, and when this interaction occurs, then through the process of diabetes, the lymphocytes, activated lymphocytes, are able to cross the endothelial wall, go to the lamina propria. So if there's an alpha-4 beta-7 integrin inhibitor, the interaction with MATCAM will not occur. The lymphocyte will not be able to go across the endothelial wall or will not be able to reach the site of inflammation, and that is how vedolizumab acts. Th1 and Th17 are major pathways of inflammation, both for ulcerative colitis and Crohn's disease. For Crohn's, I would say more, and for ulcerative colitis, again, Th2 and Th17 are major pathways. Th1, IL-2 has two subunits, P40 and P35. IL-23, which is a main cytokine of Th17, has two subunits, P40 and P19. So what do you find out there? A common subunit out here, P40. So if you block P40, you're going to block both IL-12 as well as IL-23 pathway. In other words, two major pathways, Th1 and Th2, and that is what ustekinumab does. So ustekinumab blocks IL-12 as well as IL-23. So obviously, possibly a better mechanism of action than just blocking one cytokine, that is TNF alpha. Then the class of drugs has come up which probably are going to be the most successful. And these are P19 inhibitors. In the previous slide, if you look at it, you find that P19 is a subunit of IL-23. So P19 inhibitor would block only IL-23 or Th17 pathway. And this class of drugs is risankizumab, mirikizumab, and gusellikizumab. Intuitive thinking would be that ustekinumab, which blocks IL-12 and IL-23, should be more powerful, should be able to downgrade inflammation much more than P19 inhibitors, because P19 is only blocking IL-23 pathway. But recent head-to-head trials have come out with very startling conclusion, that large RCT, which showed that P19 inhibitors have proved to be much more effective than IL-12-23 inhibitor, that is ustekinumab. The possible reason for that could be obviously when you're blocking such cytokine pathways, you're blocking some helper, the regulatory and helper cells also. That could be the reason. But in any case, P19 inhibitors are found to be clinically much more successful. Then comes the oral small molecules or blocking the cell signaling pathways. That is, all these interleukins, IL-2, IL-6, IL-10, they get attached to the cell receptor of a lymphocyte, cell membrane of a lymphocyte, and thereafter there's a cell signaling pathway by which they go to the nucleus so as to generate the pro-inflammatory markers. So if you can block that cell signaling pathway, obviously you'll be able to block multiple cytokines. That cell signaling pathway is JAK-STAT pathway. So you have the Janus kinase inhibitor, that is tofacitinib. It will be able to block the cell signaling pathway. That will be able to downgrade inflammation in form of blocking many cytokines, not just one cytokine, but any cytokine which gets attached to the cell membrane. So came up tofacitinib, which is a JAK1, JAK2, JAK3 type 3 inhibitor, a pan-JAK inhibitor. A next generation JAK inhibitor has also come up, which is upadacitinib, which is only a JAK1 inhibitor. Upadacitinib is also probably going to come into the market in India this year. And upadacitinib, despite being again a selective JAK1 inhibitor, has been found to be maybe a little bit shade better, I would say, than tofacitinib, in the sense that in patients where tofacitinib fails, upadacitinib may be useful. Now, moving another one stream upstream, that is, why not prevent the lymphocytes from leaving the lymph nodes? Lymphocytes, where do they get activated? They get activated in lymph nodes. So if you prevent the lymphocytes from leaving the lymph nodes, maybe that would be very useful in terms of decreasing inflammation. How do lymphocytes leave the lymph nodes? Whenever there is an inflammation, there is an increase in sphingosine 1-phosphate cytokine out there, or molecule out there. So the lymphocytes, what they do is they sniff that gradient of sphingosine 1-phosphate, and that gradient leads them to the path towards the intestine. So if you have a sphingosine 1-phosphate modulator, as a result, the lymphocytes will not be able to sniff their path out, and the lymphocytes will remain retained into the lymph nodes. And there comes in S1P modulators, receptor modulators, or lymphocyte egress inhibitors, or ozanimod. Ozanimod has also been, all these drugs are also being used in various dermatological conditions. So ozanimod, basically it is a sphingosine 1-phosphate receptor modulator, whereby lymphocytes are not able to leave the lymph nodes. When they are not able to leave the lymph node, they cannot reach the site of inflammation. So you find that where we started from, cyclosporin and azathioprine, methotrexate, came up to biologicals, comes up another class of drugs, that is the oral small molecules, which is tofacitinib, upadacitinib, and ozanimod. And there's a difference between both of them. This difference is important to understand, because if you're going to give a patient these medicines, then these differences would be useful. Oral small molecules can be stored anywhere. They don't require refrigeration. The cost of manufacturing them is very low compared to biologicals. So as a result, tofacitinib is very cheap, less expensive and cheap compared to biologics. So it is easily available for the common person. The route is oral, more comfortable to the patient. Onset of action is much faster. Patient comfort is better. At the same time, they may be subject to hepatic and renal metabolism, so they cannot be given in patients with chronic renal failure or liver disease, and adverse events may be more generalized. So the half-life of infliximab may be 8 to 12 days, vedolizumab may be 25 days, ustekinumab may be 19 days. In other words, this is the kind of time they take to act. Whereas for tofacitinib, few hours, 6 to 8 hours. Upadacitinib, less than a day. That shows that not only they are effective, they are very fast. So if you want to control inflammation, these are the agents you will want to give. If a patient does not have very profound inflammation and you want to control the inflammation slowly, vedolizumab, ustekinumab may be excellent choices out there. So you have extracellular, as I showed you, extracellular targeted drugs. You can target, these drugs can target the whole pathway from where the lymphocyte gets activated in the lymph node. You can block it with the help of ozanimod. Then the lymphocyte goes to the blood venule, and from there it has to go into the lamina propria. There the lymphocyte trafficking inhibitor alpha-4 beta-7 will control that action, so that the lymphocyte does not go into the lamina propria. Once the lymphocyte goes into the lamina propria, there obviously it can block TNF alpha, it can block IL-12, 23, it can block IL-23 only. Those agents can act out there, and still besides that, within the lymphocyte, if you want to block the mechanism of action, then you have the JAK-STAT inhibitors. So there are various ways by which you can control inflammation. Despite that, most of these drugs do not give you control in more than 60% of patients. That is what we call as a therapeutic ceiling. A therapeutic ceiling means that you would expect that these drugs are going to have a wonderful effect for the patient, but no. Biologics, they are proteins, they are monoclonal antibodies. So obviously, antibodies will form against proteins. So their mechanism subsequently, efficacy is bound to decrease. There's redundancy of immune pathways. There are too many immune pathways. You block one immune pathway, the other immune pathway gets activated. So that is why there is a therapeutic ceiling, and the clinical remission rates are at best 30 to 50%. So now let's come to when would you like to give advanced therapy, that is biologics or oral small molecules. Both in ulcerative colitis and Crohn's disease, one indication remains the same, that is steroid-dependent disease, azathioprine refractory or intolerant disease, and you want to control inflammation. Then there's a divergence subsequently. In Crohn's disease, you have what is known as top-down therapy. As I told you that if you identify aggressive cases which have stricturing disease, perianal fistulizing disease, fistulizing phenotype, there you would like to give straight away advanced therapy in the form of biologics or oral small molecules. Whereas in ulcerative colitis, there is nothing like a top-down therapy as yet. You have to gradually step up. That is a patient who is steroid dependent, steroid refractory, not responding, you will put them on advanced therapy. Then in Crohn's disease, after post-surgery, since the recurrence chances are high, you may have to give advanced therapy. In ulcerative colitis, surgery is curative, so you may not have to give advanced therapy out there, except that certain cases when they developed recurrent antibiotic refractory pouchitis or Crohn's disease of the pouch, there you may have to give advanced therapy. When not to give them? If a case has active infection, never think about it. Untreated tuberculosis, none of these agents. Active malignancy, again, it is what I would say gray zone. You would think before starting biologics. Amongst the biologics which you can think about giving is vedolizumab or ustekinumab in such a kind of setting. Otherwise, you would think about starting biologics or oral small molecules. Anti-TNF definite contraindications are congestive cardiac failure or demyelinating disease. JAK inhibitors definite contraindications are thromboembolism, elderly with CVA or CAD, child cirrhotic or chronic renal failure. Cirrhosis and renal failure because oral small molecules are by the liver and the renal route. Now let's come to the latest guidelines on what do the AGA guidelines tell us, and then we'll also look at the how do you adapt them to India. So the interesting thing about the latest guideline which came up was they called it as a living guideline. I am not aware of any other guideline in gastroenterology, hepatology, endoscopy or anywhere where they've named it as a living guideline. Living guideline means that allows for operationalization of guidelines during the development process with updating of individual recommendations based on the availability of new evidence. Why so? The reason is that if there were 7 drugs which are approved before 2020, after 2020 in 5 years again 7 drugs have been approved, another 3 or 4 drugs are waiting. So that is the kind of explosion which is taking place in the field of IBD therapeutics. So the authors decided that let's name it as a living guideline because it will have to be redated, re-updated every 6 months or so. And the indications of biological therapy in ulcerative colitis in a way remain the same, that is patients with corticosteroid dependence or refractory symptoms. Yet at the same time, what they have added is if somebody has mild symptom but has a very high burden of inflammation, there you would like to think of giving biological therapy or advanced therapy. Now, this slide is a little complicated. I'll deconstruct it in the next slide. So what they talked about is that you have patients who have been exposed to biological therapy before and who have not been exposed to biological therapy before. Patients who have been exposed to biological therapy before, they always have a poor, lesser rate of success when you give them the next agent. Patients who have never been exposed to any of the advanced therapy, the chances of success are much higher. So if a patient has never been exposed to any advanced therapy, there the higher efficacy medication would be infliximab or vedolizumab or the oral small molecules. Adalimumab would be a lower efficacy medication, particularly in a case of ulcerative colitis. Whereas if a patient has been exposed to advanced therapy, then in that case, anti-TNFs go down, vedolizumab goes down, oral small molecules like tofacitinib or upadacitinib or IL-12/23 inhibitors like ustekinumab or P19 come up. So if I deconstruct it a little, then we find that, let's say we have a steroid-dependent ulcerative colitis patient who is not responding to azathioprine. You all obviously have two kinds of patients out here, like patients who can afford and patients who cannot afford. So one is on the right side, one is on the left-hand side. And these are the various agents which are available today in India. Then which agent would you like to give? Infliximab, very much, would remain amongst the first choices. Adalimumab, not in ulcerative colitis. In Crohn's disease, adalimumab has equal efficacy to infliximab, but in ulcerative colitis, adalimumab is inferior. So you may not like to start as a first-line therapy. Vedolizumab, yes, vedolizumab can be first line of therapy. Ustekinumab, probably yes, probably no. Surgery, always keep surgery in mind because surgery is curative and at the same time can be cost effective. Tofacitinib can also be an excellent line of therapy because in the sense that it is effective and at the same time if it is cheap. If any of these agents fail and you have to switch to the next line, there's failure of first line advanced therapy, then the choices are tofacitinib or ustekinumab. Now again, let's say there is a steroid-dependent ulcerative colitis patient who is elderly, prone to infection, or previous recent history of malignancy, again not responding to azathioprine. So what are you going to do out here? Here, the choices will remain vedolizumab or ustekinumab. Why? Because these are the two safest drugs, and the setting out here is that the focus is on safety. Efficacy obviously needs to be there, but here the most strongest point out here is that you need a safety factor is very important. Elderly patient, prone to infection, with recent history of malignancy, etc. So you realize that if you are going to position the advanced therapy, the decision pathway has to be based not only on the clinical situation, ulcerative colitis, Crohn's disease, and their subsets, the efficacy in that subset, the safety, as well as the cost. So I'm just trying to explore the situation from 2 or 3 different viewpoints so that you get an idea about which agent to use in which setting. So let's say if a patient in ulcerative colitis, there are 4 factors: high disease burden, safety, failure of first advanced therapy, and cost. High disease burden, then one would like to use infliximab. Always add azathioprine to it because infliximab is efficacious only when azathioprine is added. You can use tofacitinib also, you can use vedolizumab also. If safety is an important factor, then you would like to use vedolizumab or ustekinumab. If there's a failure of first-line advanced therapy, then you can use tofacitinib, ustekinumab, vedolizumab, and if nothing works, then adalimumab. When it comes to cost, you have biosimilars which are available for the biologics, and they are an excellent choice. Their efficacy is as good as the original molecule, so they can be used, and tofacitinib obviously is there. Some caveats out here is that, as I told you, adalimumab is inferior to infliximab and vedolizumab in ulcerative colitis. Is ustekinumab as good as infliximab as first-line therapy in ulcerative colitis? Probably yes, probably no. Here I would say it is a knowledge gap. In acute severe ulcerative colitis, infliximab can be used, cyclosporin can be used, tofacitinib can be used, or surgery can be a choice. Vedolizumab, adalimumab have no role in acute severe ulcerative colitis. Vedolizumab has higher efficacy in bio-naive than in bio-experienced patients, and if a patient has extraintestinal manifestations, again, you would like to use infliximab or tofacitinib or this thing. In Crohn's disease, if I look at the same scenario again, if there's a high disease burden, then adalimumab jumps up. You can use infliximab or adalimumab. You have a choice to use any one of them. Ustekinumab can be used. Tofacitinib is not effective in Crohn's disease, so it should not be used, whereas upadacitinib, which is a JAK inhibitor, is efficacious in Crohn's disease, so it can be used. When it comes to safety, again, ustekinumab and vedolizumab are two agents for you. And if there's a failure of first advanced therapy, then upadacitinib, ustekinumab, adalimumab, or infliximab can be used. So the caveats out here is that unlike ulcerative colitis, infliximab and adalimumab have equal efficacy in Crohn's disease. Ustekinumab is probably as good as infliximab as first-line therapy in Crohn's disease. Perianal Crohn's disease, anti-TNF first line of therapy, ustekinumab may be used. If there is a stricturing or fistulizing Crohn's disease, anti-TNF therapy or ustekinumab can be used. Okay. So whom not to select? In other words, if I want to make it simpler for you, acute severe ulcerative colitis, do not use adalimumab, vedolizumab, or ustekinumab. Crohn's disease, do not use tofacitinib. You can use it, but evidence does not suggest it. Sometimes when the patient really cannot afford drugs, has only Crohn's colitis, you end up using tofacitinib. But no, as a regular standard of care, no. Perianal fistulizing disease, vedolizumab would not be effective. Infliximab, adalimumab would be effective, or ustekinumab may be given. If there is extraintestinal manifestations, vedolizumab preferable, not to select it, because vedolizumab in fact causes arthralgias, it increases arthralgias. If a patient has thromboembolism, CAD or CABA, do not use tofacitinib. Pregnancy, all these drugs are safe except tofacitinib. Elderly with comorbidities, tofacitinib, infliximab, adalimumab, these should not be given. Demyelinating disease, infliximab or adalimumab, the anti-TNF inhibitors should not be given. Then you have to give certain adjunct therapies along with them. Adjunct therapies is low dose azathioprine or methotrexate, which may be 50 milligrams of azathioprine or 15 milligram subcutaneously methotrexate weekly. With infliximab and adalimumab, we should always start them because that improves the efficacy of these two drugs. You may give them for 6 months to 1 year. With vedolizumab and ustekinumab, we do not require them unless until the patient has refractory disease and you want to add the next line of therapy. With tofacitinib, do not combine azathioprine. There is no logic as of now in combining. Subsequently, studies may come up, but not as of now. Remember that there's a primary non-response to all of these drugs, which occurs in 20 to 30% of patients. So don't be, but at the same time, don't be in a hurry to stop them. We often see patient has been given 1 injection of infliximab, not responding, move over to vedolizumab within 3-4 weeks. Do not do that. There's a time to assess response, which ranges from 8 to 12 weeks for all these agents. So wait, once you've started drug, unless until the patient is having very severe symptoms, watch for the response for 8 to 12 weeks, complete the induction dosing before you decide that the patient has a primary non-response. There's a secondary loss of response also occurs. As I told you, patient is not doing very well, comes back 6-8 months later, not doing well. That also occurs in 30% of patients. So there, for infliximab, you have drug levels and antibodies available, which you can measure. For vedolizumab and ustekinumab, they are not required because the antibodies formed are very low. Adalimumab, we do not have that level available in India, but you can do therapeutic drug monitoring. Often it is said that anti-TNF leads to TB reactivation because you're blocking TNF, so obviously the TB which is dormant or bacillus dormant out there gets reactivated, but you can easily avoid them and avoid the reactivation of TB. That is by doing a stringent latent TB screening. And remember, this is not only for anti-TNF, it is for vedolizumab, ustekinumab, tofacitinib. As we have seen cases of vedolizumab-induced TB reactivation, ustekinumab-induced TB reactivation, tofacitinib-induced TB reactivation. So you need to do 3 tests: the Montour, the skin test, the IGRA, and would preferably do a CT test rather than a chest X-ray, and look for any past history of TB. If any one of them is positive, even if the CT test shows evidence of old TB, put the patient on chemoprophylaxis, which can be with the help of INH for 9 months, rifampicin for 6 months, or INH and rifampicin for 4 months. And if you use this strategy, what was seen at our center was that the risk reduction was from 17% to 1.7%. That kind of drastic risk reduction with such a simple strategy. So don't be afraid of using anti-TNF inhibitors thinking that it's a TB endemic region or something like that. Now, 2 or 3 basic slides. That is mesalamine. When you are using, add topical mesalamine. This is a very interesting data which shows that the clinical response, endoscopic response, histological response to oral mesalamine all jumped up by 10 to 20% when topical mesalamine was added, even in patients who had pancolitis or left colitis. We are all used to giving topical mesalamine only in patients with proctitis. No, in E2, E3, that is pancolitis, left colitis also, you would like to add topical mesalamine. There are 2 kinds of second generation steroids available, that is budesonide, so MMX and CR. Budesonide you would be using so much in autoimmune hepatitis, so you know that it has first pass metabolism which is 90%, so as a result the side effects are low. But there are 2 preparations available. The MMX preparation gets released in the colon. So if it is a case of ulcerative colitis, you would like to give budesonide MMX. The controlled release preparation gets released somewhere into the proximal ileum, and also if the patient has Crohn's disease affecting the ileocolonic area, then you would like to give budesonide controlled release. This is a kind of confusion often made at times because in the sense the names are so similar that people end up mixing up them. A few slides on tofacitinib because tofacitinib is used a lot nowadays. So when to use tofacitinib? All cases of ulcerative colitis wherever you are planning biologics. Crohn's disease, as I told you, not to use it. Where is tofacitinib being used indiscriminately? That is, a patient should have been put on 5 ASA. That is the first line of therapy. Straight away tofacitinib is started because it is very effective. Or if the patient has failed 5-ASA first time only and then you want to start steroids are not added and straight away tofacitinib is given. Sometimes the gray zone is that you can, when you're starting azathioprine, then you can think in terms of whether to start tofa or azathioprine, but definitely do not use it as first line therapy. Why it can't be used as first line therapy? Because US it comes with a black box warning. It has definite history of sudden cardiac death, CAD, CVA, thromboembolism, risk of infection, herpes zoster, fine, that is mild. But the major thing is risk of sudden cardiac death and all, so it is not as safe as 5-ASAs and etc. So it cannot be used as first line therapy. And like with all drugs, you need to screen for TB as well as thromboembolism in cases when you start tofacitinib. The induction dosing is 10 milligram twice a day for 8 weeks. Maintenance dose is 5 milligrams twice a day. How long induction therapy can be continued? 16 weeks instead of 8 weeks. And maintenance, you can keep on continuing it for 5 to 7 years. It's not that you have to stop it in 1 year or 2 years. In a case of acute severe ulcerative colitis, till now, if a patient was not responding to steroids, we always thought we had only infliximab or cyclosporin as choice. Tofacitinib is another choice, but the dose is 10 milligrams thrice a day for 3 to 5 days. Thromboprophylaxis is a must in this setting because tofacitinib predisposes to thromboembolism. Thereafter, you can decrease the dose to 10 milligram for 8 weeks and then 5 milligram, the way you do it. Steroid tapering has to be faster. But remember, high doses initially for a few days, 3 to 5 days, and thromboprophylaxis is a must if you're going to use in the setting of acute severe ulcerative colitis. No need to combine with azathioprine. If a patient is doing well on tofacitinib, you can stop 5-ASA as well. In case of flare while on tofa, patient is on 5 milligram tofa and the patient comes back with a flare, no need to think of additional drug. But just increase the dose back to induction dosing of 10 milligram twice a day. You can also add steroids for some time, add topical therapy and see what happens. If the patient is still not responding, then we can talk about dual therapy, that is adding another advanced therapy agent. If a patient develops herpes, you can stop tofa and can restart later. It is not a contraindication for not restarting. In most cases of IBD, whenever we're planning advanced therapy, it is not only for tofacitinib. One would like to give the vaccine for herpes zoster. The recombinant vaccine is available, which can be given. And particularly if you're planning to start a patient on tofacitinib, it is advisable to give the recombinant vaccine. If a patient develops thromboembolism, stop tofacitinib and never restart tofacitinib again. Herpes zoster, you can easily restart. Thromboembolism, it would be, if you have other choices, please do not go back to tofacitinib. Now, whatever we have learned, I'll take you through 1 or 2 cases in terms of, let's look at it, that to apply on it, like how in real life these case scenarios move. So there's a young lady who came with recurrent intestinal colic in 2015 with low albumin, capsule endoscopy showing proximal jejunum and ileal ulcers. She was diagnosed as having Crohn's disease, and thereafter azathioprine was given, infliximab was given, 6 doses received, there was no response. She continued to deteriorate, so switched over to adalimumab, initial response, but again thereafter the patient continued to have anemia, recurrent colicky abdomen pain. Adalimumab was intensified, that there was a loss of response, we started giving it weekly. Patient develops alopecia areata because of adalimumab. A lot of these autoimmune reactions paradoxically can develop with the biologicals, anti-TNF inhibitors, as well as ustekinumab, etc. So the patient was switched over to ustekinumab. We are given infliximab, adalimumab, now ustekinumab. Patient says there are certain mood swings, still we continue. The patient develops palmoplantar psoriasis. So again, managed with topical steroids. Now by this time the patient has increase in inflammation with increase in CRP and a CT showing small collection in the terminal ileum. 6 months later she had to be admitted because she's on ustekinumab. Obviously she has developed a penetrating disease near the ileum and there's a small collection out there. So what are you going to do in such a kind of setting? Now the only choice left for you is obviously you'd give 2 biological therapies or you go in for surgery. So the patient was went in for surgery and a limited right hemicolectomy was done out there. Thereafter, immediately post-op started on adalimumab, again develops alopecia, so shifted to ustekinumab and she seems to be doing well. So this is a kind of scenario which occurs in a case of difficult to treat Crohn's disease. Or this 50-year-old man who came in 2019 with colonoscopy terminal ileal ulcers, given anti-tubercular therapy initially, thought to have tuberculosis, did not respond, continued to have increase in symptoms, and thereafter he was put on adalimumab. With adalimumab, he was on adalimumab, azathioprine for good 6 months to 1 year, had a partial response, had recurrence of symptoms in between, and endoscopically there was no healing. The CT showed that there was a loop of ileum which was distinctly thickened and inflamed. So the question is, what do you do? Do you switch over to ustekinumab? Yes, that is one choice. Do you switch over to vedolizumab? Maybe, but ustekinumab would be a better agent. But yes, there's another line of therapy which is available out here for terminal ileal disease, that is surgery. So the patient was advised surgery, and that was a great option, because what has been seen that particularly in terminal ileal disease, if there is less than 40 centimeter involvement, non-structuring disease, their biologics or advanced therapy and surgery seemed to be doing equally well. There was a good randomized control head-to-head trial which was done, which showed that when you did give one arm biologicals, infliximab, and another arm, the patient straight away went for laparoscopic surgery. So the initial 1-year data and 5-year data both showed that surgical results were better, and subsequently also a large population-based cohort study came out which showed that ileocecal resection performs as well as biologics. So surgery has a role to play in cases of Crohn's disease. Surgery is very helpful in cases of Crohn's disease. Do not avoid surgery just because you think that after surgery there would be a post-operative recurrence in Crohn's disease. Now 2 slides on primary sclerosing cholangitis, primary because that is something which you would be seeing often. So primary sclerosing cholangitis with IBD, how would you treat? Can you give biologics out there or not? For obviously for primary sclerosing cholangitis, you're the experts and you know that UDCA is like Brexit, like in the sense the British Society guidelines saying that you do not give UDCA at all, and ESCL guidelines saying that, okay, these are guidelines saying that you can give 15 milligram per kg of UDCA at all, do not give 30 milligram of kg. So biologics are not effective for primary sclerosing cholangitis. They may be effective for colitis, so they can be given in a patient of PSC with IBD. So we have cases of AIH, PSC with IBD, and they are on biologics. They are doing well. Vedolizumab, but amongst the biologics, what was seen was that vedolizumab possibly seems to be leading to an increase in the liver enzyme levels. Rest of the biologics were doing well, but again, this is very initial data. At this moment, whatever cases we have, when they require biologics, we start with infliximab. If they do not respond, then we move out to vedolizumab, and some of the cases are doing like that. Another good agent to treat both colitis as well as PSC, and particularly PSC, is vancomycin. In cases with PSC, IBD, we have seen some spectacular benefit when you have given them long-term vancomycin, that you give them vancomycin from 3 to 6 months, and that seems to have a good effect, not only in the cholestatic picture, but also on the colitis part at all. Post-liver transplant, azathioprine is favored over mycophenolate as maintenance therapy whenever you are doing PSC with colitis, and you can also give anti-TNF therapy along with CNIs, provided that azathioprine has been stopped and all. Then the new thing which is coming up is the cases of, as more cases become more aggressive, you have what is known as CAT, or combined advanced targeted therapy, which simply means that you combine 2 agents. A patient is on infliximab, you add vedolizumab. A patient is on adalimumab, you add ustekinumab. A patient is on tofacitinib, you can add vedolizumab. The only combinations which are not permissible is that do not add tofacitinib to anti-TNF inhibitor. The reason being that tofacitinib and anti-TNF inhibitor, both of them have the highest risk of serious adverse events. So you do not want to add 2 agents which have the highest risk of serious adverse agents. And this is generally done in a new entity, which is again the difficult to treat disease. That is, you have given 2 biologics with different mechanisms of action. Patient is not responding to that. Patient has had surgery twice. Still the patient has a recurrence. A complex perianal disease, chronic antibiotic refractory pouchitis, or a patient who has major psychosocial complications that impair disease management. So these difficult to treat patients are there. Now, the acute severe ulcerative colitis, we have all be talking of giving IV steroids. Patient does not respond, give cyclosporin or infliximab. This is a typical case scenario to show. Like 22, a patient comes with on steroids and 5-ASA, exacerbation, azathioprine given, develops acute severe ulcerative colitis in 2023. IV steroids given, patient does not benefit. Switched over to infliximab plus azathioprine. Patient did well for 2 months and came back again with another course of IV steroids. Infliximab was stopped, and this time tofacitinib was started for the patient. Patient did well, offered surgery at every step, but patient did not want to undergo surgery. Again comes the relapse. So vedolizumab was added to tofacitinib. So this is the kind of dual biological or dual advanced therapy which is often being offered to patients when the patient is not initially responding, because essentially it is a balance between inflammation and the control of that inflammation with immune modifying drugs. Another case, 43-year-old male, Crohn's disease, stricturing small intestinal disease, underwent surgery straight away, first of all. Thereafter, a few years later, put on adalimumab, partial response. Switched over to ustekinumab, partial response. Methotrexate added, again no response. Continues to have hemoglobin of 7.4. What do you do out here? So you can add another biological out here. The patient can go in for surgery, or you can repeat the induction therapy for ustekinumab. That is the kind of complexity which is coming when you are treating such advanced therapy cases. But then remember that whatever you may do, when the patient is given first-line advanced therapy, the chances of success are 60%. They diminish when the patient is sequenced to the next line of therapy. That is, let us say the patient was started on tofacitinib, failed, started on infliximab. The success would be only 40%. Infliximab failed, patient started on vedolizumab, chance of success would be again 40-50%. It fails, patient started on ustekinumab, chances of success are only 25%. So that is the kind of scenario which emerges. So in the end, I would say that yes, the kaleidoscope or the canvas is huge. You have a huge number of agents to play with, but play with them very responsibly, because the problem starts right at the point of diagnosis making to there are a lot of twists and turns in between. Thank you so much for your attention.